I'm going to start us off, though, by um, something that Beethoven said, I'd just like to expand a little upon. And I think this is also my theory for running this conference is nothing goes to plan, but that doesn't mean you shouldn't have a plan.
Yes.
Expand upon that a little bit. How do you keep that sort of freewheeling uh, experience going and people willing to go along with, I don't know what to do next?
I mean, I think that's why we have such a long training period so that people can get used to receiving a call from 988, triaging that call, having one set of information and arriving on the call and having a completely different scenario unfold. And it is trained into us from day one. We start running calls with our clinical partners that we're going to talk through this whole scenario and get there, and it's not the same. And so I think in having folks run calls at a very early start in their career with us, it really allows them to learn how to improvise and keep safe while on a call and help people.
I can
By
speak to that a little
anything
bit.
addition?
Yeah, for sure. I think about worldview a lot when I think about this. And, everybody's perspective is going to be a little bit different. And,
Hmm.
sometimes when we go out on a call, maybe we're getting all the information we're getting is coming from maybe a neighbor who has then called the
Yeah.
crisis line, who has then been transferred to our county crisis line. And then they said this information multiple times. And then by the time we hear the information, we're hearing it from, a operator from our crisis line. So every one of those people in this weird game of telephone that we play sometimes puts their own spin on it. And they do that from their own worldview. So that initial neighbor who's called maybe is thinking about, wow, I'm really worried about the things this person is saying, and maybe I'm a little scared. So that, things that they're hearing are from that place or saying are from that place of fear. And then by the time it gets to us, it's been translated through a clinical lens by the crisis line where they're talking about these things as symptoms, maybe. So, I always just want to approach things thinking that, that the information might in some way be accurate, but it's from an entirely different perspective. And, the best information, is always from the person that we're trying to serve. And, we talk about people as being the expert on their own experience. And that doesn't mean that we shouldn't have information when we go in, but it means that we should allow a space for this person to explain what it means to them and like what is actually going on with them, what their experience is. Um, I mean, I think most of our staff can probably say that the number of times that they went out on a call and what was going on was exactly what they were told is probably pretty close to zero. Like it's always a little bit different. It's always from a little bit different perspective. So
So you really must look for people in your hiring recruitment process who relish that experience, who enjoy the curiosity, enjoy the variety.
Absolutely.
absolutely. When we talked about in our presentation, that's there's a lot of really great peers out there that don't have that. They want to build a relationship with somebody over a long period of time
Hmm.
and do really great work. But folks that do this particular work really well find this entertaining. Like they like to be really fast paced. They like to think on their feet. They always have a quick thing to say. They're always really curious about what somebody's
Yeah.
perspective is. And honestly, like if you walk away from this presentation with one thing, it's curiosity is key. Like that is what I really want people to remember is like we look for people that are curious. They're curious about people's experience. They're curious about the community. They're curious about like what your perspective is, and they do that without judgment.
Hmm.
It is a divine comedy, isn't it? You have to just keep a light heart. So Mary M, in our last session, had a question for Steve Michio, which I think would be a good question for you. And if Amir, can you bring Mary M into the panel, and we'll get the question answered. Well, while we're waiting, I'll ask the question and see if, she'll be able to give a follow-up. Question's really about information sharing with law enforcement and HIPAA. And what are your guidelines around that? What can you do? How does information sharing work with your law enforcement partners?
For sure, I can take that one. So most of our communication with law enforcement is either one way, meaning they give us information, or it's specifically about immediate safety. So, just for instance, in 2025, we worked with law enforcement on about 14% of our calls. And of those 14%, 8% were times where they were already there and they called us. So
Hmm.
they responded to a 911 call and they got there and they're like, this is behavioral health related. Like we're not the solution
What are
here.
we doing here?
Yeah, so they called us and they stayed on scene. So the majority of our communication is them telling us things like, hey, this person told us this thing, like this is not criminal, but this person obviously really needs help and we don't know what to do. So we have a lot of those kind of conversations. And then when we share information, though, it is strictly about immediate safety. One of the things that I've found, which was kind of surprising to me when I first started working with law enforcement, is um, when they call us, like they're viewing, us as the primary on the call, to use their language. So they want to be our backup. So when we show up, they want us to tell them rather, like what to do, what to expect. So that's part of what we do as soon as we arrive and say, hey, you know, thanks for being here. We have a report that there are weapons present. Like, I'd really appreciate it if you would walk in, make sure this room is safe, and then step back and let us engage with the person and just stand by in case something unsafe happens. And then they'll follow our instructions with that kind of thing. So as far as additionally, like responding with HIPAA and things like that, like we don't ever share any protected health information with law enforcement. And it really is all about safety.
Mary Ann, are you in the room? Can you hear us?
I can.
Here we go. You have a follow-up question, Mary Ann?
Yeah, I think, when I heard in the last presentation just the strong communication with law enforcement, saying it was daily and constant, we'll be able to not only inform them disposition of a response, but be able to share like ongoing linkage and follow-up. I was wondering, with HIPAA, how they're able to navigate that. We have really good relationships with our law enforcement partners, but often what we run into is they are wanting to know that information to respond more appropriately,
Hmm.
and our legal has, said, no, you can't even share the disposition with them. You can't let them know of anything about ongoing linkage and follow-up that we're doing. Even people that are on, court orders for their mental health treatment, they've said that we can't share any information, and not that we want to share more than need to know, but really want to, engage them in this partnership with us when appropriate.
Clay, you want to respond?
For sure. Yeah. So I honestly, I don't think we get asked that by our law enforcement here in Portland. We will share, and I know people use the word disposition in a lot of different ways, but we will share like, did we go or not? And did we make contact or not? But beyond that, we would not share any information. And that's really about all we're ever asked by law enforcement partners. We do have a behavioral health unit as part of the Portland Police and the Gresham Police Bureaus that have clinicians on their team, and we actually have peer specialists who are part of my team that work with the Gresham Behavioral Health Unit as well. So on those teams, they do share maybe a little more information because it is, but it is a police response, not a mobile crisis response, really, that happens to have some behavioral health support. But yeah, we've not really run into police asking us for a lot of information. They seem to respect, that we want to remain separate. Also, just for aside from legal reasons, but for practical reasons, if people wanted to talk to the police, then they would be calling the police, and they would, and if somebody wants a behavioral health response, sometimes having an unnecessary police involvement or presence is not supportive and can actually turn them off from talking to us at all. So we do stay separate as possible.
Okay, and that's good to know. That's what we're trying to move towards, is having less of a police response, but still just not, fully there yet. And we appreciate that our law enforcement partners, when they do have to be that first responder, want to be doing that in a way that is as supportive as they can be until a mental health professional can get on scene. So thank you.
Thank
Now,
you.
Clay and Beethoven, just a nuance here. If someone shows you their medical bottle and says, "I have just taken all of my olanzapine, all 32 pills. Thank you very much." At that point, you're going to share information with law enforcement and
Yeah.
everybody else
Absolutely.
along the pipeline.
Yeah, absolutely. To me, and again, that when we talk about immediate danger, like it can be danger to self or others. So if somebody says that they've already taken action in their life, then we're going to absolutely, engage services to get them help. But we're also going to do that in the most like pure and trauma-informed way possible. We don't overreact when stuff happens. Like we make sure we take the necessary steps to get somebody help. And like in that circumstance, like we'd of course be calling an ambulance right away, and we'd be saying, "Thank you so much for sharing that with me. I'm really glad that you did." And to me, that means that you might want to get some help for that. Would you be willing to go to the hospital when this ambulance arrives? And like really try to, engage somebody in going voluntarily to get help in that setting.
And in addition, just going off of what Clay said earlier, the police really are looking for us to be the lead in these calls. So if the police arrive because they have to, because someone has taken action to end their life, the police are asking us, how would you like this to go? How involved do you want us to be? We can stand outside of the door and wait for you guys. Like we are directing the scene.
So this is a effect of a mature mobile crisis operation. You guys have been doing this for 30 plus years. It just
Yeah.
makes sense that that the police now know, law enforcement knows, and they tell each other, and there's an understanding.
Yes, I think part of our tenure is part of that, but it's also very intentional on our part as well. We train with the police, the entire team once a year, every year, with the Portland Police Bureau. We go out to their scenario village and work with the behavioral health unit and other officers that respond to our calls and like do safety training so that we build that relationship. The officers see what we're going to do. They see so that, in a training environment. We also participate in the academy and in ECIT training. There's recorded trainings done by us that are part of police bureau training and stuff as well. So I would say that every police officer knows who we are and has a general idea of what we do. And we work really hard to continue to build that relationship every time we encounter officers.
That's very interesting. Because so many teams have started in the past few years. We just talked to Steve Michio with People USA a few minutes ago, and Steve's running a program for 25 plus years. And here you guys are with a mature program. You really are. And there's a handful of them around the country that really have done this for a while. And you're really seeing very different effects in the community at this point, 25, 30 years in, than a team would say 5 years in or 10 years in. And do you see that changes your relationship with organizations aside from law enforcement, say hospital or adjacent agencies?
That's a tough one too. I'm still a little shocked as long as we've been doing this, how often we run into people and they're like, "You work with who again? Like, who are you?" And I'm like,
Hmm.
"Oh, really?" So like I do think it's an ever moving target. It doesn't really matter how long you've been around. There's always a new hospital social worker, there's always a new community partner, there's always a brand new nonprofit that like doesn't really understand yet. So we actually have a pretty engaged campaign. We call it public relations for PR, PR for PR, where we're like actively meeting with, we try to do at least a couple a month every month, and we have for a while now, where we present to some community partners team meeting. Our team did an amazing service project for the holidays this year, and they baked cookies for all of the hospital social work staff and emergency department staff, and like delivered those to the folks that we interface with there, and be like, "Hey, like we see you, we care about you, and by the way, don't forget who we are." So we do a lot of that kind of stuff, and we do that both externally with our community partners and also within the agency at Cascadia. Cascadia is a huge agency with almost 1,200 employees, and a ton of different departments. So I go to staff meetings and team huddles and stuff like that, and be like, "Hey, by the way, crisis services, if you ever need us, this is what we can do and how we can help you." And it's definitely a never-ending conversation.
So you have an internal PR campaign as well as an external PR campaign, just to remind people you're around.
Yes,
100%.
It's
absolutely.
that big.
Yes, and even our peers on just a one-on-one basis, part of what they do in their follow-up work is making community partnerships. So we encourage them to reach out to shelters to get trained on how to refer staff or refer clients. We really want our agency to make partnerships in the community that are beneficial for everyone.
Steve spoke about follow-ups. Are you able to do follow-ups?
Yes.
Tell
Yeah.
me about the importance of doing follow-ups.
Follow-up is infinitely important. We believe that moving someone, not just moving the needle from from crisis intervention to stabilization is where we should be. And we have our peer providers 1 day a week. They each have a day where they're in the community meeting with participants that have been internally referred to our peer program, doing follow-up of clients, helping end the cycle of needing crisis and then needing crisis and then being okay and then needing crisis and then being okay. We're implementing our peers in ending those cycles and helping people achieve long-term support and wellness.
And that can look like a lot of different things for different people. So we try to avoid like arbitrary timelines. This is not a 2-week follow-up program or a 1-month follow-up program. We also try to avoid like very prescriptive things like, well, we're going to refer you to mental health outpatient services at Cascadia, and then you're going to be okay, because we know for a fact that that's not the right fit for everybody. We do have access to that if that's what somebody needs, but we really work to meet with people and make a person-directed plan and then help them to execute that plan. And sometimes that's calling somebody and saying, hey, like, I helped you get that referral for therapy. Did you go? Did you like it? Do you want to do it again? Should we start over? Sometimes it's wow, like, I know you're really anxious to talk to your primary care doctor about like this thing you shared. Like, how about I go with you and just sit there with you while you explain what your experience is. It can be, a lot of the folks that we serve are experiencing a variety of like social and situational like insecurities. So sometimes it's like, hey, going to the food bank kind of sucks. Like, how about I help you navigate that and figure out what that's like to access some food resources, or talk to somebody about rental assistance or whatever the thing is that is the driver of some of these things that turned into a behavioral health crisis.
And is that an advantage of being part of a community mental health center, that you can shift from being crisis to support, from crisis to support, and just continue the relationship?
I do think we definitely have some advantages being part of a large agency like Cascadia. I work very closely with other departments. We have, integrated team-based care that provides ongoing peer support for folks that are in that level of service. And like, we meet with those peers and say, hey, here's, Jason, and I've been working with him for a month, and I'm so glad to introduce you to him, and you can continue working with him. But there's also an element of it too that, um, Cascadia, as big as it is, doesn't meet all the need, or we're at capacity sometimes. So we do work really closely with external partners too. Um, but I'm sure as happens across the country, even in Portland too, like there's some gaps in the system that just aren't filled. And that is one of the bigger challenges that we run into during follow-up is like, wow, like this person needs a thing and that thing doesn't exist. So we back up from that point and start talking about like, how do we come up with something different that would help, or how do we, how can you be okay without that thing, whatever it might be.
And
Wow.
something we do pertaining to follow-up is I meet with each of my supervisees on their follow-up day every week to offer that support, to offer planning, and when these things come up where there just isn't a support for a client, it's very impactful for our staff. We want to be able to help someone. So we offer just an emotional place to meet, a planning session, and a good job because they're doing amazing work.
Well, that brings up Amanda Thompson's question. And Amanda, if you could unmute and come ask your question of Beethoven and Clay.
Yeah, hi. My question was about the supervision of peers when you're talking about like the impact of this work. Because one of the things that I noticed from like our clinical partners is trying to find ways that feel supportive and structured, but don't edge into this territory of like peer fragility and don't like reinforce hierarchy on the teams also. So when I heard you sort of say, like, we're doing a lot of check-ins, we're asking about the impact of the work, how are you all making sure that your supervision with peers is about the impact of the work and doesn't get into the territory of like providing therapy for people where they're like compelled to talk about like their lived experience and how that like connects to work, like in an oversharing or maybe even like problematic way? Like, how do you keep it centered on the work?
Beethoven, you want that or you want me to?
Well, to be honest, I don't think that sharing about your personal experience is oversharing. We're sharing our personal experiences every single day with our clients. Why we wouldn't we be sharing them in supervision is kind of how I feel about it. And I mean, personally, I'm a peer. I'm not trained to be a therapist. I don't have those credentials, so I don't even know how to do therapy. But what I can offer is really in-depth discussion about what it means to share those experiences and the impact of that exact thing. Because it is really hard sometimes when you over-identify with a client because you have the same exact lived experience. Um, or not being able to help someone and then feeling that same helplessness because you weren't helped because that gap in the system still exists. Um, I think we are allowed to be more personable or personal because our job is very personal. Clay, do you have an addition?
Yeah, for sure. And Beethoven, you can write on. I think about supervision as peer support in a lot of ways. And I have absolutely been supporting somebody and said, "Hey, wow, that sounds like something you should talk about with your therapist." And I say that in supervision sometimes too. And and I try to identify that boundary. And talking about a person's experience of a thing that's recent that you're working on, talking about how you want to react differently when this thing happens, like all those things are within bounds. But if things get to the point where like, wow, like this thing happened in my childhood and I can't stop thinking about it, like that would be one of those like areas where we're like, wow, that sounds like that's something you should talk to a therapist about and that you could work through with a therapist. One of the things that I love about working in an interdisciplinary team is that we have a lot of respect for clinical work, and we also see its difference, and we understand where that line is sometimes. And yeah, it moves. There's no definitive answers here. I love the social workers that I work with, and I say all the time that the one thing I've learned from them is that there's more nuance to everything. You can, and there really is in this context as well. So I think the way to do that, to answer your question directly, is to have direct conversations about it. Kind is clear, and be like, "Hey, wow, I feel like we're drifting into territory that might be therapy. What do you think?" And like let's have those conversations very openly. But I don't have any perfect answers. I've absolutely had some supervisions that didn't go great. And but the key is to be really intentional and open and honest about those conversations and to keep pushing through it, just like you would with any peer that you're serving.
And just to add on a little bit more, I'm a very blunt person. I really don't have a filter. And so, like, in my supervisions, I have absolutely no problem stopping and being like, hey, this is impacting you more than just a work level. And once it goes from this is more than a work impact, this is a life impact, that's when I really hone in and say, okay, therapy time. Like this is where you have to talk to an outside provider or support because I can't help you process these things and you need help processing them. And I think we're allowed to say that to our supervisees because of the role we're in as peers supporting peers. Um, and you know, I think just me being a supervisor and all of my co-supervisors being clinical, I've actually switched their model up a little bit in how they're doing their supervisions because their staff are impacted as well. And they have people with lived experiences that are clinicians impacted by the work in the same way that peers are. So I think this is maybe a shift that I'd like to see everyone do.
It seems to be that this is the really the difference between peers and non-peers. Is peers we're going to talk about it, non-peers we're going to pretend it didn't happen.
Mm-hmm.
And if you
Absolutely.
value the experience that peers bring to the team, you're going to have to do this additional level of engagement.
100%.
Do you get into trouble? We've got a couple of people asking, but we're going to go a little long on this session because this is so interesting. We're going to get to everybody's questions. Have you experienced positions where you got into trouble, into professional trouble, and talking to people where suddenly you were shifting ground and you weren't, suddenly you were in personal territory and you shouldn't have been?
I can't say that I've gotten in trouble in that way, but like again, like as we're walking through things, like I'm really candid about stuff, and like when people say things that I don't think they say, whoa, hey, I'm going to stop you right there, just like I would in any conversation with anybody, and that really sounds like something that is outside of our professional relationship that we shouldn't talk about. But I also think that like as peer providers, it's really important to recognize, and we share this with all of our peers, that like I have an ethical responsibility as a peer provider to take
Hmm.
care of myself and to be able to, and that might mean go to therapy, that might mean take medication, that might mean meditation, that might mean none of those things, whatever it is, but I have an ethical opportunity or responsibility to take care of myself enough to be able to do my job. And that does come up sometimes where we have to say with folks like, wow, like I'm really worried about you. You don't seem like you're taking care of yourself. And we don't delve into that territory or into details because we are in a professional setting, but I can say like, here are some things that have worked for me. And, just like I would supporting another peer, it's same thing with supervision. I'd share some things that work for me, take it or leave it. We do refer our staff to the resources that are available. We have an employee assistance program, and a variety of other things through our people and culture department that if things reach that level, I'll say, I'm going to stop you right there. I think you should talk to people in culture and ask for, some support or something along those lines.
Thanks, Clay. I'm going to go and ask Janea to come into the meeting and ask her question about training. Janea, are you with us?
Hi there. I am Corinne with Cambridge Heart. I don't know if you meant to unmute me, but I do have a training question.
Oh, yes, there you go.
Thank you.
The names are a little confusing through Zoom. Go
Thanks so
ahead.
much. Thanks so much. I'm Corinne with Cambridge Heart. We provide peer crisis and follow-up support in our community. And I'm curious what HR or legal employment difference, if any, you have between trainees and peers. So for example, if the training time is without a time limit, does that mean trainees are getting full benefits and full salary? And do you ever let someone go if they're just in training for too long without graduating?
Thanks, Corinne. Those are great questions. So we do have a 6-month probationary period for all Cascadia employees across the board. It doesn't matter if they're peers or not. But beyond that, people, all of our staff are all union representatives or union represented. So people start at the wage that they're going to make the day they start. And there's no real difference in, pay or benefits or anything like that because they're in training. I believe our benefits don't actually kick in for 3 months upon hire, but that's again across the agency for everybody in clinical or peer roles. And then we have
Answer your que-
had I can think of one circumstance where somebody like, wasn't going to graduate from training and we supported them in finding a different role within the agency that worked for them. That's one of the benefits of being part of a large agency is that there's other things going on. So, if somebody's not going to graduate from training, they know that too, and they're not happy and they don't want to be here. And like, we'll help them find something's a better fit.
I'll vouch that Cascadia has a great HR department.
We
They can
do.
make anything happen. Corinne, did that answer your question?
It sure did. Thank you so much.
Thanks. And I think we do have Janaya now. Can you hear us, Janaya? Are you off mute?
Yes, can you hear me?
Yeah.
So yeah, my question was just, I know you guys discussed the training a little bit, and I wanted to know, is it any different trainings that you have between like peers and like regular staff, or do you like have them do the same types of trainings? And I also want to know that like, do you have like a in-house like trainer that you have assigned, or do you like do outsourced training, like find different things in the area or the community?
Yes to all of that. So we do have a couple trainings that our peer providers take that don't apply to our clinical training. So like, again, our boundaries are different, so we have to talk about them differently. So there's a boundaries training specifically for peer providers that the peers take, that's a little different than what the clinicians take. But we try to standardize things across the board as much as possible. And we do have peer providers take some trainings that are geared toward clinicians, even if they're not going to use those tools, just so they understand what the clinicians are doing. Because that I think that is an important thing to understand. As far as the specific trainings we mentioned in our session, we do have internal trainers at Cascadia that do counseling on access to lethal means, applied suicide intervention skills training, and motivational interviewing. Um, and we have outsourced for some other training in the past, but we're not currently doing that right now. So everything we do is either through a learning management system, we use Relias, or it's live training done by actual staff.
And when it comes to the staff training, just like a peer shadows a peer who works with a clinician will shadow a clinician who works with a peer. That relationship goes both ways, and those trainings happen just the same way.
Thank you. And then I wanted to know too, is the staff that's doing the training, is it like their sole job is training, or do they do anything else on top of that? And I guess I will also ask is, do you have any like routine, I would say like routine trainings, like any guides or anything like that? Like how did you come up to like the trainings? How did you come up with the thought of the trainings that everyone would take?
So some of the, trainings that we do are all required by the state here in Oregon. So the Oregon Health Authority has in the Oregon Administrative Rules outlined specific things that all mobile crisis staff have to take. And then everything that's in addition to that is stuff that we've identified and that we've assigned. Um, our trainers, we do have a training department at Cascadia, and we do get some support from them on occasion, but everything that's crisis specific is done by us. So like our suicide prevention training is all peers and clinicians that have done the work, that are actively working in other roles that step out of that to do that training. Um, One of our clinicians who's been with us 25 years does assist in OCOM with me, and she's spectacular and brings that real experience to the training. So I think that's really important.
And then for individual training, like the live training, the training that happens every day, staff members will volunteer to be a trainer. They get a bonus for it. They get paid a little more per hour, and they have someone to write their notes for free for the entire time of training. So it's pretty fun, and it's really all of our team is very sociable. They're very bubbly people. And so they love training. They like introducing the person around. They like being involved in seeing someone grow. I think that's just a trait that everyone on a crisis team has is we all want to see people grow and learn and change. And so I think that that is something that people really enjoy.
Great, thank you.
Thanks, Janaya. Good questions. Training is such an important component here. We often overlook it. And the training across the country as I visit with teams goes from 0 to 150%. There are some teams out there where it's just like, were you hospitalized once? Great. You're on the team. Let's go outside and meet some people. That's it. That's the training. And then there's some teams that we're going to train you for weeks. And Cascadia is one of those.
Mhm.
Do you find that additional training helps with retention?
I think so, and that's something that we've when we think about retention too, like from day one, like I want people to grow into what they want to grow into. And if that means that they want to be, an expert at resources, if they want to become a clinician, if they want to become a supervisor, if they want to stay in their peer role forever and just learn how to do that really, really well, like whatever their want is, we want to encourage that from day one. we have some peers who have mental health experience that, don't have a lot of substance use experience, and that's an interest of theirs. So they're learning about, substance use, and vice versa. We have some folks that are in recovery and maybe only have a, cursory understanding of some mental health stuff, and that's a real interest of theirs, and they're learning about that. So we do take time in supervision to do, talk about people's interests and find things that, would be supportive and stuff for them.
And I think a longer training period has more supervision, honestly. And that supervision is where Clay is talking about, life's work skills, personal skills growth, but also just that extra added support where one day a week you get to talk about all of the wild things you've seen for the previous week and where you're at in your mind with training and your comfortability with training and the work that you're doing. I think that extra support, at least for me when I went through training, because I was a peer on the team and now was promoted to supervisor, that for me was the most support I've ever gotten transitioning into a job ever. And it really did allow me to not only feel comfortable with the work, but feel comfortable with the team because your partner is introducing you to all of the different clinicians. You're getting to work with everyone on your team, and it makes the transition into a new job where you don't know anyone, you don't know what's going on, and it's kind of scary. Far less scary, and for people who have anxiety, far less anxious. At least it did for me.
I want to put in a plug for our union too. So, I think it's a really supportive thing. All of our crisis staff are all unionized, and they're part of Ask Me, and I can never remember what it stands for. I think it's the American Federation for Municipal Employees and some other letter stuff in there. But they have a program that Cascadia has partnered with on them called United We Heal. And as far as ongoing training goes, professional development training, United We Heal offers some free college programs. They offer a program where folks can apprentice to become a qualified mental health associate, which is like a bachelor's level equivalent in Oregon. And they also just started a qualified mental health professional apprentice program where folks are even getting to go to graduate school for free. Again, like I want options to be available for peers, and like those are some great ones, but I also really respect peers that don't want to gain additional clinical training, and we really make an effort to support them in doing that too, to grow in their peer skills, and not do that if that's not something they're interested in. But those are options that are available now.
I want to bring Jordan in to ask a question. Jordan's in New York City, but his question is very relevant to Portland, Oregon. Jordan, are you with us?
Thanks, Jason. Hi, Clay and Beethoven. Thank you both for your presentation. I was curious about the situation that comes up for some local crisis teams on very rare instances in which it's determined that the person would be safer with further evaluation in an ER. And in teams where a peer is an integral part of the model.
Jordan, I'm sorry. I'm going to ask you, could you pick up the handset? We're having a hard time hearing you.
Oh, is this better?
You're on a speakerphone, I think.
Let me try something else. Is this better?
No.
Are you hearing me any better?
No.
Okay, I'm
You
sorry.
get very close to your microphone.
I don't really know where the microphone is in this room. I'm sorry.
Well, muster through. I'll restate it if I need to.
Yeah, I think I'm hearing you okay. So
go ahead, Jordan.
Yeah, the question is just how do you manage that tension between on those rare occasions when a person does need further evaluation in an ER and has to be transported, but like if they're not voluntarily, like I don't know about Project Respond, but I guess I should back up and ask, does Project Respond do arrange for or request involuntary transport? Okay, so you said nodding yes.
Yeah.
So in those situations, how do you navigate that tension between needing to involuntarily transport someone to an ER for further eval versus anything coercive is antithetical to peer values, right? So it's such a kind of a tricky line to kind of walk along or move along. So I'm curious like how Project Respond handles that. Thank you for being my
Absolutely. Yeah, absolutely, Jordan. I think it's a really great question. And yes, involuntary transport is something that does happen on some of PR's calls. If I remember right, based on our 2025 statistics, it was less than 4% of the calls that we went on ended up in a director's custody hold, is what they call that in Oregon. Some basic things from the peer perspective. For one, like this is one of the first things I mentioned in my phone screening with people, because there are some peers out there that don't want anything to do with this. They don't want to be there when that happens, and that's like a non-starter for them. So I try to be really candid. Like, yeah, this is a thing that sometimes happens. You might be present when somebody is compelled to go to the hospital against their will. Um, and then beyond that, like I really take, the supportive approach, and like I make it really clear that as a peer, like I'm not involved in that decision. Um, and I want to support you because this thing is happening. And I'm sorry, this might be terrible. This might be really scary. But there's nothing I can do about that. And I still want this to go as well as it can for you. And like I know several of our team have had some really great responses, like by like sitting in an ambulance with somebody and like riding to the hospital with them so that they can help stay calm. Whatever it takes to make this as easy as possible for somebody so that they can get the help that they need. And then maintaining, true to our peer values. And that's, like, I'm not going to tell you what to do. I'm here, but I'm not involved in that decision to tell you what to do. And I want to offer you support while this is happening. Um, but I will say that, sometimes as peers too, we just have to step back. And that is, if somebody is being, put in an ambulance, and, they're not in a place where they can hear or understand us, or they don't want us to be there. Sometimes we just have to step back and allow the last tool that our system has to, take effect, to be used.
Just to add on a little bit to what Clay said, in the moment when you have to be there, and the person is responsive to you and is talking to you, like Clay said, I was not involved in this decision, but I am your advocate. What do you need in this moment to feel safe? And what do you want me to tell the hospital? And that's where we go. It's how can I advocate for you further in this situation?
Jordan, did that answer your question?
Yeah, thank you, Beethoven and Clay. I really appreciate both of those responses.
Thanks for asking, Jordan. That's such an important question.
Clay and Beethoven, how often does this scenario happen?
Like I said, it's about 4% of our total calls in 2025. I would say yeah, it's
Or
not a ton.
very small.
I would say that, we did go on about 3,000 calls in 2025. So, it's not it's not a zero number for sure. But I would say the majority of the holds that our team writes also, like, folks are going voluntarily. There's, no one's using force against them or anything like that. And a circumstance that our clinicians run into sometimes in Oregon is that if somebody goes to the hospital voluntarily, sometimes they just like get seen by a nurse and get dismissed, even if their circumstances are pretty serious still. Whereas if a clinician writes a hold, the person has to, at the very least, be seen by a physician that can write some sort of evaluation. So there are times, even when people are asking to go to the hospital, that our clinicians will write a hold because they want to make sure that they get that full evaluation by an actual physician. But we work really hard with our community partners and try to partner with these systems, but they're broken in a lot of ways, and I'll be candid about that. Like we've had people that went to the hospital and got released within a matter of minutes, and then we got called immediately out to see them again. So like that does happen, and we try to give that feedback to our partners in the hospital system, and try to work through those details from a supervisory perspective when that happens. But it's definitely not a problem that we have solved.
Yeah, I think that's a special circumstance, not just in Oregon, but in many states where there is no room at the inn. People are very frightened that they will have to stay at the hospital forever. And frankly, we just haven't invested in that part of our continuum, and no, we don't have any. You have to go home now.
Yeah.
Yeah.
Hmm. Let me ask a question. I've got a question from Lynette coming up in a moment about peer support work in Oregon, but I want to ask about another thing, Beethoven, that term that you use, peer drift, and peers, supervised peers. Tell
Yes.
me what you mean by peer drift.
Peer drift is when a peer starts to act outside of their role as a peer. So, working with clinicians or working with a team of clinicians, we can start to move the needle of peer over a little bit into clinical thought and clinical work. And so, peers, training peers, we're trying to not only like train peers as peers by peers, but telling folks like, hey, I noticed you had this thought or this reaction or this whatever. Have you thought about how that's clinical and not from a peer perspective?
Mm.
Having those conversations where you're like, hey, I actually think that's the clinical model that you're talking about. How
Hmm.
can we navigate this situation as peers? What would it look like to divest entirely from the clinical model and only look at this situation from a peer lens and a place of peer perspective? And that's what we really try and do with our peers by teaching peers and supervising peers as peers. Because uh, on a team of clinicians, it is very hard. And I think I have like a really wonderful bonus on my team that all of my co-supervisors are clinicians and I'm argumentative. I will have conversations with the clinical supervisors where I'm like, I think you're absolutely wrong. Have you considered these perspectives? Have you considered this lived experience? And I think this model or this route will affect the client we're talking about here in a much better way than the clinical model at this point.
Hmm.
And having those conversations in front of staff so that we can model that so that staff can take it in that it is okay to be a peer and it is okay to be a clinician and it's okay for us to talk to each other and disagree.
It's really about that comfortability being, in having hard conversations. I mean, and we say this a lot, like we all have hard conversations for a living. That's what we do, and we should be equally prepared to do that with each other, and with each other as peers, with each other as clinicians and peers. Beethoven and I argue, like,
Yeah, we
that's part of
do.
the work. It's part of the work. And I do want to say with peer drift, like no one's doing anything wrong. It is a natural phenomenon that occurs, and it can be systemic and it can be personal. So like peer drift can be the way you set your program up can cause peer drift. Like if you have peers that have to do a suicide screening, for instance, that's like right there on the cusp because that pushes people into drift. But you also, have the drift that's like a really personal effect of like working with people. Like, people want to fit in. People want to fit in with the people that they work with every day, and we naturally sometimes begin to mimic language that other people use. And sometimes, if we work with clinicians that use pathologizing language or use acronyms all the time, we start picking those things up. And it takes naming it, and it takes active and conscious effort to not do that. Like I never say SI for suicidal ideation, although clinicians say that around me all the time. I always say a person with thoughts of suicide because I think it's really important that we remain person-centered and as plain language as possible when we talk about stuff like that. I'm on a campaign to eliminate acronyms, and I'm terribly losing as I'm speaking at the AMSA conference, I guess. But I think acronyms are terrible, and I think that it just adds to this confusion and this mystification of our already incredibly complex system. So, clinicians say really clinical stuff to me, and I repeat it back in plain language, and don't comment on it a lot because I just want to make sure that I'm reinforcing that that's how I want to speak. Um, so yeah, peer drift is something we think about and talk about a lot, and
So
it's
this seems to be part of sort of the ecology of a community mental health center, that you have a power differential, you have a class education differential, you have a pay, salary, equity issue. How do you keep that sorted out politically within your organization and continue to assert your independence and legitimacy.
Gosh, that's tough, Jason. We continue to talk about it. We don't make the same as our clinical partners, and we do a lot of the same work sometimes, and that's really tough sometimes. There are clinical supervisors that make more than me as manager, and that's the reality of the circumstances. And we try to advocate as best that we can in a lot of ways. And sometimes that works, sometimes it doesn't. But we don't quit. We don't give up. And Beethoven does an amazing job, and I hear it all the time at simple, things like shift change or in like walk by conversations in the office where we're like, hey, hold on a second, like there's another perspective here that I want you to hear. And sometimes we make an amazing impact and things change because of the things we say. Other times, we compromise. We meet in the middle on some things. Master's degrees are expensive. Clinicians need to make a livable wage and still be able to pay their student loans. Like that's important. But at the same time, we want that equality as much as possible. And I try to remind people too that our involvement is what the consumer feedback says is necessary right now. Any consumer survey of mobile crisis or crisis services in general is going to say that people want to talk to other people that have had similar experiences. We're not just an add-on to the system. Like we're what people want the system to be, is to include peers.
And like at least at a programmatic level for me as a supervisor, I'm right now working with my co-supervisors to come up with peer-centered trainings for the whole staff. Because I noticed we had clinical centered trainings for the whole staff, and I was like, nope, we're going to do peer-centered trainings for everyone. The clinicians will sit with us and do this work together because we have to learn their roles. They must be acquainted with ours to the best that we can train them. And I'm really enjoying thinking with clinical supervisors as well, coming up as an equal with them, creating trainings to support both of our programs within the same program. And it's nice to work within Cascadia where I can do that. I can be creative. We can come up with new things.
We've got one last question for this session from Lynette, and Lynette is I don't know. Let me ask before Beethoven play. We're all here out on the Pacific Coast in Oregon. We think we're doing great as far as peer services and peer awareness and peer development. Do you feel the same? Do you feel that this is something special here?
No, I don't. Like I want to. I really do. I really want to. I would love to say that we're the leaders in all these things, but then I hear people like Steve Michio, like who did that last presentation. I'm like, wow, like we've got a lot to learn. So the Copeland Center, for instance, does one of the leaders in the peer movement right now, on the East Coast. And so I think there's a lot of great things that we're doing, but I also think it's really important that we're learning from folks from across the country, and that's why the work that you're doing, Jason, is so important, and that's why we're really so glad to be here. I really do hope that folks take me up on our offer at the end of our presentation and reach out. I would love to talk to other folks that do this work or that have questions. Please feel free to email us. That would be so awesome.
We'll have your email addresses, this recording, the recording of your session, and your slide deck, which I think I have, all in a post-conference email, which will go out to everyone. So, but one last question from Lynette. She's trying to break into the business. Lynette, are you with us?
Yeah, I'm here. Can you hear me?
Hey.
Yeah.
So, as a person who has a lot of lived experience with the mental health of the aspect of life, as well as the addiction, I recently got my peer support certification, and my ongoing work internally has been so wonderful. But what I'm realizing as I'm looking for a job and wanting to get into it, it's like people want you to have experience. And I'm thinking, well, how do you break into the experience unless you're given a chance? And the other part of it would be I'm really liking everything you both are saying, Beethoven and Clay, because what I've discovered in my own journey is that we have a huge gap in the healing parts of things. You know, you get out of treatment and then you're gone. You don't, you know, who's going to follow up with you or want to walk alongside of you and say, how are things going? And so um, yeah, I'm just wondering if you have any recommendations. I am going to be moving to the Portland area because I live in Astoria right now, and it's a pretty small town. And my heart's desire is to do this work. I've spent my whole life with PTSD and not realized what it was until a lot later in life. And so, you know, I have a lot of compassion, a lot of understanding, and I'm just at the beginning of my journey here. So, any advice you have for me would be wonderful.
Absolutely. I've got a couple things off the top of my head, Lynette. First, it's a really great question. And the two things that I think about is starting out in a peer role. Um, yeah, there's a bunch of them out there that require experience and specific experience. You're absolutely right about that. And some of the things you can do to mitigate that. The one thing is like look for a specific peer role that lines up with your specific lived experience. So, for instance, part of my story is experiencing homelessness. And I got my start on a team that worked in a homeless shelter. So like when I interviewed for that job, I didn't just say, "Hey, I'm a peer with some experience." I said, "Hey, I'm a peer and I have specific experience that the specific team that I'm applying to is working on." So I think that's really important because not all peer jobs are created equally. There's a huge variety of them. And as someone that hires a lot of people and does a lot of interviews, like that's what I look for is like specific lived experience that matches the lived experience of the people that a specific team is serving. And then the other thing that really shows initiative for me is doing other trainings. So there are plenty of free trainings out there in the community and out there in the world that you can do, like mental health first aid, suicide prevention trainings like QPR, question, persuade, refer, and there's a tons of different stuff out there. Being able to throw a few of those things on your resume is a really good indicator to a hiring manager that like you have some initiative to continue to learn and to continue your journey into the professional world of peer support. I see my colleague Lisa dropped in the question there. Please check out cascadiahealth.org/careers. We have close to 70 peer positions across the agency, and I know some of our programs are hiring right now. In the Portland area, I also really recommend the Peer Company. They're also known as the Mental Health Addictions Association of Oregon. And they have a variety of different, they're a peer run agency. It has a variety of different programs. So they're a really great place to start.
Another thing I'll add is if you have the time, find places to volunteer. You know, Clay hired me. This was my first peer job, paid peer job, but I had worked in domestic violence and sexual assault. I had been a peer, and then I had also been a peer with NAMI and volunteered with both organizations. And, you know, volunteering, A, get your foot in the door, but B, you get to see what you like about the job, what you dislike, what you like, and where your skills can grow to.
And it's a weird
I see mutual
occupation.
mutual aid groups is another one that's really helpful too. You know, working with I did Smart Recovery before I started working professionally as a peer and was facilitator for that and stuff. And that was also like really helpful to kind of get my foot in the door of the like this is kind of what these people do. So
It's a weird occupation. It's not like you graduate from high school and said, I'm going to become a peer worker. It's a special kind of club.
it
It's
absolutely
hard to
is.
join. But once you've joined, it's hard to give up. Got one last question from, it's a little bit separate topic from Dawn Carter, and I'm just going to read it. It's, what is your peer supervisor to peer staff ratio? And does this change based on the number of staff and the probationary period?
So it doesn't change based on our probationary period piece. Unfortunately, I just ask Beethoven to work harder when they're training people. And yeah, that just happened. That happens
Does
that
that
way.
work
But like
out?
the
It
golden,
does.
yeah, the golden number is 10, but we kind of go a little in either way based on like FTE or full-time equivalency. So like we have some on-call employees that only, that so they don't count as much as a full-time person as far as like the administrative burden of being a supervisor. So how many do you have right now, Beethoven?
I have 6 full-time and 3 part-time,
Yeah.
3 per diem. Yeah.
That sounds manageable. Is that manageable, Beethoven?
Oh, absolutely. I told Clay I was going to take a vacation when he let me stop hiring people, but we're hiring people all the time still. So
Hey,
that'll
Lynette,
grow, and I'm
they're hiring
excited.
at Cascadia.
We
Yes.
absolutely are. Yeah.
Well, thanks to you both. This has been a great presentation, great Q&A. Congratulations on your program. Best of luck.
Thank
Thank
you.
you so much, Jason. We really appreciate this opportunity, and thank you all for these great questions.
For full